All right, next lecture we're going to talk a little bit about some special features at the knee, shoulder, and hip joints. And no, we are not going to go into the depth that your textbook is. And quite a bit of this actually is anatomy rather than physiology. It's kind of a mixture of both, but I've included it over here on the physiology side because I think you guys have plenty of anatomy already just with the skeletal system and learning all the bones and the features. So I've blended the joint information in over here on the physiology side. Okay, so the knee, the hip, and the shoulder joints, they have all those features that we talked about synovial joints having in general, joint capsules and synovial membranes and those types of things. But these joints each have some additional features I'm going to talk a little bit about. All right, the knee joint, largest, most complex joint of the body, which makes sense, bears a lot of weight, as we all know. And also, as we all know, it is a location that causes lots of problems in people. Many people have knee surgeries. Athletes or people as they get older have trouble with their knee joints. All right, there are actually 3 joints that are located at the knee. They're surrounded, though, by a single joint cavity, so all of these joints are more or less blended together. So you have the femoropatellar joint, so that's the joint between the femur and the patella. So the patella, again, is your little kneecap bone. And if you think about the shape of the patella, it's flat, and it is sitting there up against the epiphysis portion of the femur. And so that's a type of plane joint. So you have a gliding motion between those two bones. So when your knee is flexing, knee flexion is what happens when you take the lower part of your leg and bring it inward towards the back of your leg. That's knee flexion. Or when you squat down from standing, you are flexing the knee joint. Flexion, that joint term refers to bringing 2 bones closer together at a joint. Extension generally refers to moving the bones away from each other at a joint. Flexion versus extension, those are opposite terms. All right, then you have your lateral and medial tibiofemoral joints. Those are the other 2 that you have at the knee. So between the lateral and medial condyles, down there at the distal end of the femur, remember those from the anatomy side, and where they are articulating with the lateral and medial condyles of the tibia. All right, the movements that you have here, of course, that's a hinge type joint that you have between those 2 condyles there at the distal end of the femur and the top of the tibia. So you have flexion, extension, and some rotation of the knee a little bit. You can take your knee and move it this way or that way a little bit, not a whole lot. Mainly the knee functions as a hinge joint where you're rotating around that one axis, as you, like when you're squatting down and you bring the lower leg inward toward the upper leg. Notice here too the C-shaped lateral and medial menisci. Menisci, that's the plural form of meniscus. Those are some special fibrous cartilage pads that you have, and they have a C shape to them, and they're sitting on top of the tibia, and that's actually the point of contact between the femur and the tibia. You have some extra padding at that location, and you have probably heard of somebody before who has torn a meniscus. All right, this is a diagram, a lateral diagram through the right knee joint, showing you some of the features here at the knee joint. And I'm actually going to bring up visible body. I'm going to pause and hook up visible body because that's going to give us a better view of the knee joint than these diagrams from the textbook will, but I do want to point out a few features here. Lateral and meniscus And let's see, they didn't put in the other meniscus over there. Okay, that is a fibrocartilage padding that you have there at the knee joint. You also have a medial meniscus as well over on the other side. We're looking at a lateral view of the knee joint. And then you've got a couple of ligaments that connect the femur and the tibia in kind of a crisscross type pattern. One of those is called the anterior cruciate. Cruciate refers to a crisscross type pattern. So you've got an anterior cruciate ligament, and then you have a posterior cruciate ligament as well, indicated there on the diagram. And they make a crisscross and help hold those two bones together. And those are also called, the anterior cruciate ligament is the ACL, posterior cruciate ligament would be the PCL, and you probably have heard of somebody before who has torn their ACL. That's not an uncommon sports injury. We'll take a look at that as well on visible body. It's much easier to visualize on visible body than it is here. All right, here's the patella over here. So as we mentioned, you have a planar joint right in here between the patella and the epiphysis portion, the widened portion of the femur down there at the distal end. And notice you've got a couple of bursae here. Let me erase what I've already drawn on there. You have a bursa right here that sits over the patella. That's called the subcutaneous prepatellar bursa. So if we think about the language there, subcutaneous, so it's beneath, remember cutaneous can refer to the skin, so it's beneath the skin, like the subcutaneous layer or the hypodermis. Prepatellar, so before the patella, so in front of the patella. So that is a bursa, which again, that's like a little flattened sac of fibrous tissue with a synovial membrane deeper inside that secretes synovial fluid. So that helps cushion the patella, provide some cushioning for it. It's not unusual for people to develop bursitis and have inflammation within that bursa. You've also got another bursa over here. This is called the deep infrapatellar bursa. So again, the name, this is a deeper bursa. Notice it's actually behind. There's a ligament right there, the patellar ligament, that it's sitting behind. So it's between that ligament and the tibia. So it's providing some cushioning between those two things. Infrapatellar, infra, inferior. It's inferior to the patella. And notice too, you've got some fatty tissue in there as well, providing some cushioning. And then otherwise, you have your usual articular cartilages, and you've got your joint capsule. There's part of it over there, and the rest of it's going to be over in here. And you've got that synovial membrane on the inside that's secreting synovial fluid. So you've got synovial fluid providing lubrication between those bones in there. I'm going to pause this for a second. I'm going to bring up visible body so we can take a better look at the knee joint. Okay, I brought visible body up, so here's our knee joint. This is really going to help us visualize some of these structures that we have there a little bit better. All right, so there's your patella, or your kneecap bone. And remember, you do actually have a bursa that would be superficial to that, but that's been stripped off on visible body on this view. And notice here you've got a ligament that is connecting the patella to the tibia down in there. Notice that ligament, what it's attached to, if you guys remember the tibial tuberosity right in there, that bump. And you guys are going to learn in Unit 4 when we're studying the muscular system, your quadriceps muscles up here, when they contract, they pull on that tendon, and that tendon is connected to the tibial tuberosity down in there, and that's what those muscles are pulling on when they contract. And because they do that, that's why you have that bump there. You have extra growth of bone where that tendon is pulling on the tibia at that location. All right, I'm going to strip that off. I'm actually going to strip the patella off there as well. And if we go over here on the side, that is a tendon called the iliotibial tract or the iliotibial band. Some of you guys who maybe run may have had a problem with that before. Let's strip that muscle off. I'm going to strip that one off. All right, and notice right in there, there is a lateral ligament. So over there on the side, collateral ligament. So it's connecting the two bones over there on the side. That's connecting the femur to the fibula over here. There's your fibula. Let me actually strip that one off as well. We can rotate around over here on this side. You've got, there's a medial collateral ligament that's connecting the femur to the tibia. Got a muscle there we're going to get rid of. Another muscle we're going to get rid of. Yet another muscle we're going to get rid of. Now we're beginning to be able to see some of these structures inside the knee joint as we rotate it around. Do some more dissection. Let's get rid of all these blood vessels and nerves. You've got lymphatic vessels there. Lots of things going on. Okay, can you see, let me highlight right there and over here. Those are the menisci, the lateral, this would be the medial side, this is the lateral side over here, the medial and the lateral meniscus. So those are fibrocartilage pads that you have here at the joint. Let me go ahead, I'm going to deselect those. I'm going to go ahead and hide the femur. So now we can look down on top of the tibia, goodbye to that muscle. So right there, that is your lateral meniscus, and over here, that's your medial meniscus. So you can see how big they are. And it's not unusual for people to have tears in those pads, and those become inflamed. They're made of dense regular connective tissue. No, I'm sorry, they're not. They're made of fibrocartilage. Cartilage does not have a good blood supply, so it's difficult for those to heal. And if they're ripped bad enough, sometimes you have to have surgery to suture them back together so that they can heal and begin to function. Also, as you get older, these meniscus pads wear down, and then you're at risk for the lateral and the medial condyles on your femur rubbing up against the lateral and the medial condyles over here on the tibia. And when you have bone rubbing up against bone, that causes a lot of pain and irritation and problems for you. All right, and then we were talking about the anterior cruciate ligament. There's that one. And I'll rotate around this way. And there's your posterior cruciate ligament. So you see how they kind of make that crisscross in the center? And those are connecting the tibia to the femur up above it and helping to anchor those two bones together. So I just wanted you guys to be able to see some of those features a little bit better. I'm going to return back to the PowerPoint now. Okay. Yeah, and here's another view from your textbook looking down on top of the tibia. There's your tibial tuberosity right there, that little bump. And here's your lateral meniscus, and here's the one on the medial side, and there's your posterior cruciate ligament, and there's your anterior cruciate ligament, or your ACL, and they've shown those cut open for you. Here's how the anterior cruciate ligament tends to get injured. If you had sustained a blow to the knee from the side, like you see there, in some cases that ACL can get torn. So that's a pretty common injury in some types of athletes when you have a blow to the side. Also notice the tibial collateral ligament over here that joins the femur to the tibia. That can get ripped open as well. Ligaments do not heal very easily, so surgery can be required to suture those ligaments back together. All right, let's talk about the shoulder joint. The shoulder joint is also called the glenohumeral joint, and hopefully you know from your Unit 3 anatomy where gleno is coming from. That's coming from the glenoid cavity. That's the compartment that the head of the humerus fits down into in the scapula. And the scapula has that glenoid fossa. That's the little depression. The cavity includes some softer tissues that extend that cavity outward more to form more of a bowl shape for the head of the humerus to fit down inside. The shoulder joint is not all that stable. If you notice here, stability is sacrificed for greater freedom of movement. So form follows function. We need a big range of motion at our shoulder joint, and because of that, the joint is not all that stable. That means it's easy to dislocate the shoulder. The head of the humerus can pop out from that glenoid cavity much easier than we would like it to. Also, as you know, people tend to have the shoulder joints bear a lot of weight as we lift things up and move things around and push things, and so the shoulder joint is very prone to injury and problems. All right, here's a frontal section, which is kind of weird to think about, but like a coronal slice through the shoulder joint over here. And so this is going to be the scapula over here, and then of course here's the head of the humerus up in here, and then here's the acromion process, or showing you part of that on the scapula. It's helping to form part of this joint. Notice some of the names here. Like I was showing you at the knee joint, you should be able to figure out where a particular ligament is located at the knee or the shoulder or the hip joint in many cases because of the name. So you've got a coracoacromial ligament. We were talking about that one before, actually. That is a ligament that joins bone to bone, and it's connecting the coracoid process on the scapula to the acromion process on the scapula, and it's helping to stabilize the shoulder joint. You have a subacromial bursa there that's sitting there underneath that ligament between that and the joint capsule around the shoulder joint, and it's not uncommon for people to develop bursitis at the shoulder joint due to overuse. Another thing you have at the shoulder joint here as well, these tendon sheaths, and what tendon sheaths are, they are fibrous connective tissue coverings. They're basically like large bursae that are wrapped around tendons. There's a tendon right there. That's a tendon that's connected to the biceps brachii muscle in the upper arm, which is better known as the biceps muscle in common everyday language. So a tendon sheath is like an extended bursa that wraps itself around a tendon to help provide some cushioning between that tendon and the bone that it is next to, or between that tendon and another tendon or another ligament, where you have lots of tendons and ligaments and joint capsules and bones all coming together and things are crowded. You need some additional cushioning. When you have tendinitis, which is not an unusual thing to have happen, a lot of times you're experiencing some inflammation in the tendon sheath. So those types of structures can get damaged, and when they get damaged, you have inflammation and you get soreness and so forth associated with that. All right, so I just wanted to point that out. And again, the glenoid cavity is not quite the same thing as the glenoid fossa. The glenoid fossa is over here. That's a feature on the scapula. You got that little depression in there, if you remember that from the anatomy side. And some of these connective tissues that you see here actually extend that depression outward and create a little bit more of a bowl for the head of the humerus to fit down inside. And that's what's actually referred to as the glenoid cavity at that location. All right, I do want you guys to be able to, if you had a question on the Unit 3 physiology test that said at which joint would you find the coracoacromial ligament, you should know that that's at the shoulder joint. But the good news is if you know your Unit 3 anatomy, you know the names of those bone features at the joints, you're going to be able to answer that without ever having to memorize where those ligaments are located. You'll be able to tell that based on the name. So at the shoulder, reinforcing ligaments, coracohumeral ligament helps support the weight of the upper limb, and then you have 3 glenohumeral ligaments between the glenoid cavity and the humerus that help provide some reinforcements there on the front side of the shoulder joint as well. So the shoulder joint's pretty complicated, and it's not uncommon to damage those ligaments and you wind up with shoulder pain, or people wind up needing surgery at the shoulder to restore proper function. Lots of tendons of muscles and ligaments and bursae and tendon sheaths, all these things squeezed together at that location gives you lots of opportunity for things to become injured. Okay, and this diagram is showing you, giving you a little bit better impression maybe about what I was talking about with the glenoid cavity. So down in here, this is where you would, oops, I forgot to turn my pen on. Down in here is where you have the glenoid fossa, and then do you see these, the articular capsule around this joint, the joint capsule, extends further out from that little pocket and helps make the cavity there deeper, and that's what we call the glenoid cavity. The glenoid labrum also consists of connective tissues that are helping to extend and deepen the cavity. You have a labrum at the hip joint as well, as we'll see in a second. All right, how about the hip joint? It's a little bit there. It's also called the coxal joint, since coxal region refers to the hip region. This is another ball and socket joint. As you guys know, that's where the head of the femur, or the ball of the femur, articulates with the acetabulum of the os coxa. You do have a good range of motion, but as I mentioned earlier, it's not quite as good as what you have at the shoulder joint. And the socket there is very deep. It's much deeper than what you have at the shoulder joint. That makes it more difficult to dislocate the hip. A hip dislocation is less common than a shoulder dislocation, but it also limits the range of motion, as you guys know. Most people cannot move their femur around as well as you can your humerus. There is another one, there is a labrum there as well, connective tissues that enhance the depth of the socket. So just like up at the glenoid cavity, you have the glenoid labrum, you do have an acetabular labrum at the hip joint. And here's a diagram showing some of these structures to you. So this is a frontal section through the hip joint. You've got a frontal section through the hip joint. One thing I do want to point out to you, the ligamentum teres. You've got a ligament there that is connected to, remember, the fovea capitis that we took a look at on the head or the ball of the femur, that little indentation. The ligamentum teres is attached to that, and then it extends over here to the os coxa, or extends over here to the bony part of the acetabulum, and that helps hold the ball of the femur in place, and that's something that provides some support, so you don't want that to get torn. And then right over in here, acetabular labrum, right in there. So you have some connective tissues that extend outward from the acetabulum and provide some depth. And keep in mind, this is in 3 dimensions, so you're just looking at a frontal section through the hip joint. That acetabular labrum is like the lip of a bowl extending upward around the acetabulum in 3 dimensions. You may have heard of somebody before having a labrum tear at the hip joint, and so that's what's happened. Part of those connective tissues there become torn and injured, which can cause lots of pain. It would also decrease the stability of the hip joint when that happens. Okay, so that was just kind of an overview of the knee, shoulder, and the hip joint. And do review some of those unique features and structures that we talked about at those 3 joints when you're studying for the exam. Our very last lecture for Unit 3 and Chapter 8 will be some joint injuries and disorders, and that will finally finish out Unit 3.